All right, our next speaker is Dr. Charles Louy, who's a good friend of mine. We've been working together for more than 20 years, treating patients with leaks. He's professor of anesthesiology, the head of the inpatient pain service, program director, and I'm looking forward to his talk.
Thank you very much for inviting me, first of all. And this is going to be a sequel to the previous two lectures I gave in 2017 and 2018 at the previous symposium on this topic. And the previous lectures are available through the Spinal CSF Leak.org website. So let's, from the historical perspective, I'm going to talk about high volume, so-called high volume epidural blood patch, and how far we can push the limit, or what's new since last year. And I'm going to mention something about safety, plus some clinical pearls, hopefully. So up to 2001, there was just a loose consensus about how much blood to inject for epidural blood patches. And it was about anywhere between 10 and 20 milliliters of blood. And then Safati-Seron in 2001 published a paper stating that perhaps we can push the limit higher. But the other part of the innovation, and higher means greater than 20 milliliters, the other part of the innovation was that the volume of blood should be limited by the development of back pain or radicular pain. Did I skip a, hold on. Yeah. So, Dr. Shivink and I started doing low thoracic epidural blood patches with the rationale that that's where one of the sites where most of the patients were leaking from. And then we noticed that in a significant number of patients, the symptoms reappeared within days. And then when we brought these patients back and did a lumbar epidural blood patch, a significant percentage of these patients had their symptoms relieved more permanently. So that's when we decided to do simultaneous thoracic and lumbar epidural blood patches. And so that was about in 2001, right after the paper published by Safati-Seron, and that's actually when I had the fortune of meeting Dr. Shivink about doing epidural blood patches, for which I'm grateful. So here's probably a key paper that has been published since the last lecture, and that was, what happened here? And that was by Pagani Esteves at the Mayo Clinic in Rochester. And they did, and that was published last year, they did a retrospective analysis of 600 epidural blood patches and looked at the factors that predicted the efficacy of these blood patches. And the volume of the blood that was injected was the actually only predictor, both in multivariate analysis and univariate analysis. The other factors that predicted efficacy on a univariate analysis, besides the volume of blood, were doing multiple levels, bilevels, and 3 levels, where in some of those 3 or more levels included a targeted blood patch. And unsurprisingly, a site-directed patch is more effective than the non-targeted patches. I think up to this point, we shouldn't be surprised. But of the bi-level approach, a lower thoracic plus lumbar was the most successful bi-level strategy. And that confirms what we recently published in terms of that cohort that I had discussed in the past 2 years. Now, if you look at the volume that we have been injecting, about 30 milliliters in the thoracic area and 16 milliliters in the lumbar area, each level is not such a high volume. However, it's the combination of the two that makes it a high volume epidural blood patches. The other thing that we need to notice is the variability of the total volume injected, because the range was anywhere from 4 milliliters to 124 milliliters. And that is an indicator of the variability of the elastance of the epidural spaces from patient to patient. So what has been the trend? So I had mentioned in a previous lecture that Griot's published the catheter-based protocol for SIH, where the average volume was 54 milliliters. And 8 out of the 9 patients that underwent this epidural blood patch had the improvement or resolution of their symptoms, and there were no complications. That was in 2014. In 2017, Wu and colleagues looked at the volumes of their epidural blood patching and determined that, again, the volume of the injected blood determines the success rate. In this case, it was about 65% for the volumes greater than 22.5 milliliters versus, I think, about 46% for the lower volume. Moving forward, also in 2017, Stott and colleagues published a case report of a patient with neurocognitive decline. And they had initially tried lower volume, small volume, single-site epidural blood patching and obtained only transient responses. Finally, they take the bull by the horn and injected 120 milliliters all via catheter and obtained a resolution of the cognitive dysfunction. More recently, in 2018, Otonari and colleagues treated 15 consecutive patients with SIH with or without chronic subdural hematoma, also with a catheter-based technique. Their average volume was about 45 milliliters with a range between 16 and 85 milliliters. And in 80% of the cases, the symptoms were relieved even when conventional blood patching or fibrin group patch had failed. They had one complication, and that was a ventral thoracic epidural hematoma, which resolved spontaneously. So what about the risks? Soon after the Pagani paper and our paper was published, Samir Narusi, also from Ohio, published an analysis of the potential complications from doing high-volume epidural blood patch. And the title of the paper, in quotation, "Epidural blood patch is an iatrogenic epidural hematoma," sets the tone for the entire paper. Now, just to summarize what they're saying, what Dr. Narusi says, is that back pain and radicular pain is due to the nerve, by the compression of the thecal sac and nerve root compression. We knew that. We should be aware of pre-existing spinal stenosis because that limits the spread of the injected blood. And you should be aware of prior surgical and epidural intervention. Now, This analysis is familiar to, I assume, to everybody in the room. But it was published, I think, for people, for practitioners who are going to decide to do high-volume epidural blood patches without having any experience. Because if you think about the best way to avoid the iatrogenic compression of the thecal sac or nerve compression is monitor the patient's symptoms. Because, as I mentioned earlier, with only 4 milliliters of blood, you can induce a radiculopathy. So, whether you're aware of the anatomy or not, you should just have continuous feedback. And the corollary of this is that we should not do these epidural blood patches on a patient who's unconscious. Now, there are other safety risks that are not mentioned in that paper, although the accidental dural puncture, I think, is a pretty standard risk, known risk. However, one of the cautions that one of the possibilities I always worry about is that after the epidurogram shows that the needle is in the right place, could the needle migrate into the intrathecal space, thereby letting us to believe that we can inject more blood than we actually should, although actually may link to the fact that we're injecting blood where we should not. So in my previous lecture, I mentioned about the protocol that I talked about, which is if you inject about at a constant rate, and I usually use about 5 milliliters per minute, and the pressure, the back pressure that you feel on your thumb on the plunger of the syringe increases, that should be an indicator that you're in the right space. However, I don't trust that anymore either. I think a better way to do this is, and I'll mention in a moment, is to mix contrast with blood, and then after 20 cc's, 20 milliliters of blood, double check that the blood went into the right place. The other potential pitfall that I want to highlight here is, obviously, if a patient had previous spine surgery, you may not have an epidural space, which could lead to, again, to an accidental dural puncture. And then the question, which could be, so previous spine surgery is one possibility. There could be scarring for a previous epidural blood patch. So the epidural space is existent, but you're not going to get the loss of resistance, so you're not going to be able to get an epidurogram until you went through into the intrathecal space, and now you've created an accidental dural puncture that is hard to repair, especially if we're going to use cutting needles. So for not just for epidural blood patching, but for doing lumbar punctures and myelograms, I think it's important to use non-cutting needles because it decreases the rate of post-dural puncture headache, especially in a patient who already has SIH. So again, I have to thank my colleagues from Duke University and Stanford for suggesting to mix blood with contrast. And then the other advantage of doing that, of mixing the blood with contrast, is that we can check a distribution of the blood, and that can provide some guidance on where you're going to inject at the next level. And that's beneficial in patients who have closed compartments, either because of prior surgery, but more likely because of prior epidural blood patching. Let's show some examples of what I'm discussing here. So this is a patient who's, you can see, can I show this? Can you see the knee? Yeah. This is the needle being inserted at T12L1 for an epidural blood patch. This is the lateral view. The needle is here. Hopefully you can see it. This is the epidurogram by injecting 1 milliliter of IOXL 240. This is the epidurogram in the AP view. And this is the injection of blood mixed with contrast in the AP view. That doesn't give you too much information, in part because the patients are actually lying on pillows which are partially already opaque. But here's the picture on the lateral view. So the needle is here, and most of the blood went rostral, some of it went caudal. And that gives us an idea where to go for the next level. And for the second level, I chose to go to L2-3, which is right almost immediately caudal to the spread of the blood in the previous picture. And one other comment here, this is an atypical spread because the patient had prior epidural blood patching, which I would have never been able to see if I had not mixed blood with contrast. All right, so back to L2-3 in the AP view, epidurogram in the lateral view with the needle being here. And this is the blood, this is blood injected at the L2-3 level mixed with contrast. So when we take a bird's eye view and after we inject more blood, again, you will note the limited spread there. But this is what happens. This is blood from the first injection, and this is blood from the second injection. Now, there is a continuous spread, except that you cannot tell from right to left. It could be that there's continuous spread, the imaging are contiguous in the lateral view, but not necessarily in the AP view. Second example, this is an epidurogram in the lateral view at T12L1. And now, after we inject blood with contrast, you will notice that the blood went practically, almost all of it went into the anterior epidural space. Usually when that happens, I put the patient also, I tilt the table just to be sure that we're not intrathecal, because it's sometimes hard to tell the difference between an intrathecal injection and an epidural injection in the lateral view. And then here's the needle, and you will notice there's a little bit of a rostral flow as well. So, now what about centers that do not have imaging? I had the opportunity to visit a couple of centers, actually one center in Italy, and talk to other anesthesiologists. And not everybody has the luxury of having a real-time fluoroscopy. But then at that point, what is the safer way to do it? And they do their epidural blood patching with the patient in the sitting position. Because if there's an accidental puncture, then you can see CSF leaking back. Whereas if you have a patient in the prone position, and you are, even though you do an accidental dural puncture, you have an accidental dural puncture, you're not going to be able to detect it. And with the people, again, these anesthesiologists I was discussing the matter with, they inject gadolinium in the blood and then get an MR to confirm the spread of the blood. Other people inject iodinated contrast and then do a CT epidurogram after that. But I hope that we're getting closer to the conclusion, or at least to the opinion that blood volume matters. And I think one of the hypotheses that I want to put forward is that if you're not injecting enough blood, the blood probably is not going to stay in one place. I think the way I look at it is that you need to inject enough blood for the blood to stay snug in the epidural space. And that means you need to inject until you have the appearance of symptoms, in spite of what the Narussi paper warns you against. A combination of targeted and non-targeted blood patching is probably the best, and I think we're going more and more in that direction. And multi-level is better than single-level patching. The question is, where should we inject? I think my hunch is that probably a lumbar plus a low thoracic plus a high thoracic, mid or high thoracic, probably will provide the best yield. Also given the fact that the epidural space is wider in the lumbar and in the high thoracic space. I think the trend toward using catheters would probably continue for epidural blood patching. I just want to add just a mixed part of clinical pearls. If a patient is 90% cured with from their symptoms, do we want to continue doing additional blood patching? I think it becomes a question of risk-benefit ratio. There are risks, obviously, in what we're doing, and we need to think about whether we want to continue doing that. I talked about the use of non-cutting needle, and then the other question remains: how long do we need to observe a patient after we do an epidural blood patch? From my reading of the literature, it may take as long as 7 hours for patients, for the blood to clot in the epidural space. So I used to keep the patient. I used to keep the patient in PACU in the recovery for 4 hours, but now I increased the recovery time to 6 hours, and also because I want to be conscious of potential delayed effects, since when we induce symptoms of back pain or radicular pain, it kind of forces me to medicate the patients, and so it creates probably a potential delay for the appearance of neurological symptoms. So preoperatively, again, in terms of safety, I think we should check for the non-existence of epidural space, because we probably don't want to do a lumbar puncture or an epidural blood patch. And known evidence of spinal stenosis, again, that's not a sufficient check, because patients may have spinal stenosis induced by prior epidural blood patching. A mandatory use of fluoroscopy or CT fluoroscopy when available, and keep the patients awake. And finally, let's not use a predetermined volume to inject, because that could lead to compression, unwanted compression. If you have any further questions, I wrote the email address of Christine Easterling. She's the assistant to the inpatient pain service. And I thank you very much. I will answer some questions at the end of the day.